CA larynx will study about the TNM classification. So we need to know that there are three regions of larynx: supraglottis, glottis, and infraglottis. This is the true vocal cord, this is the false vocal cord, this one is the quadrangular membrane, and this one is the cricovocal membrane. Okay, this is the cricoid cartilage, and these are the arytenoids. So all these regions, supraglottis, glottis, and infraglottis, has various subsites also. Now let's head into the classification system. We'll do one by one. First we'll do glottis. So T1 will be the involvement of one site only, one subsite. So one subsite of supraglottis, what can be the subsites? We can have base of tongue, we can have vallicula, we can have epiglottis, we can have AE folds. So any one of the subsite can be involved. But in T2 we have more than one subsites. Like I said, we have vallicula, we have base of tongue, medially, literally the medial wall of pyriform sinus will be there. Then we can go outside the region of supraglottis. So outside the region of supraglottis, where can it go? It can go down. Down, what do we have? So from supraglottis, it can go downwards and glottis will be involved. So if glottis gets involved, it is T2. And more than one subsite of supraglottis and glottis involved, we have T2. Then we have T3. T3, you have to just memorize that once it has gone to glottis, what do we have in glottis? We have vocal cords. So there will be vocal cord fixation, fixed. Vocal cords will be fixed. Then what else can happen? So if we have the epiglottis, here's something. We have the pre-epiglottic fold. This one is the paraglottic space, and this is the post-cricoid region behind. So all three regions, pre-epiglottic, paraglottic, post-cricoid, will be involved. Also involving the thyroid cartilage, but only the inner cortex of thyroid cartilage. Okay. Then we have T4. In this, what if inner cartilage is involved? Next will be outer cortex of thyroid cartilage and the other structures. So larynx is over. Now we have the structures that are beyond larynx. So beyond larynx, what will be there? Downwards, like this is the cricoid, we have trachea. Okay, so trachea will get involved. Then we have neck, soft tissues of the neck, and the musculature. We have deep extrinsic muscles of the tongue. We also have the strap muscles. Then thyroid gland will also get involved, and even the esophagus will get involved in T4A. Okay, and T4B. T4B is outside the larynx. We have reached the esophagus. So what is behind esophagus? We have prevertebral structures. Anteriorly, what do we have? We have mediastinal structures, and then carotid artery encasement. So that will be your T4B. Only three things you have to remember: posteriorly prevertebral structures, anteriorly mediastinal structures, and carotid artery encasement. Okay. Now let's come to our glottis part. So what happens in glottis? What do we have in glottis? We have this. What are these? These are our vocal cords. So vocal cord involvement. So if we see, these are our vocal cords. Okay, this is your anterior commissure and this will be your posterior commissure here. So T1, it is divided into two, T1A and T1B. If T1A, only one vocal cord is involved. So that vocal cord can be involved either here, or it could be that the entire vocal cord is involved, involving the anterior commissure or posterior commissure. T1B will be both the vocal cords involved. Okay, so there will be a lesion on both the vocal cords, but they are mobile. Okay, they are mobile, but only their involvement, the lesion has started. Next we have T2. So now vocal cords, what can happen in glottis region? Anything that can happen to glottis region is happening to the vocal cords. So vocal cords were normal till now, but it was involved. Now vocal cord will become impaired. Okay, and what else can happen now in T2? We know that other structures will also get involved. So from the glottis region, this is your glottis region. As I said, it can go above, it can go down below. So what is involved? Supraglottis can get involved. So subglottis can get involved. Now T3. T3 is same. We have vocal cord fixation. Okay, and some spaces will be involved, like paraglottic space around the vocal cords. Again, thyroid cartilage involved, but only inner cortex. And T4A and T4B will be same. That is, beyond larynx structures will be involved. Beyond larynx, what do we have? We have trachea, we have neck, soft tissues, we have deep extrinsic muscles of the tongue, we have thyroid gland, strap muscles, esophagus. T4B again will be same, prevertebral structures, mediastinal structures, and carotid artery. Okay, easy. Now we have subglottis. So subglottis. This is our subglottis part. Okay, so what can get involved? T1, subglottis involvement is there. T2, again, vocal cord is either normal or impaired. But where it can go? It can spread first to glottis. So it has gone till glottis now. So if it goes to glottis, T3 will again be vocal cord fixation. Then spaces will get involved. Pre-epiglottic space, paraglottic space, and thyroid cartilage. Again, the inner cortex of thyroid cartilage. Okay, T4A, the outer cortex of thyroid cartilage, and cricoid cartilage will also get involved. Then the structures that are beyond larynx. So beyond larynx, again we have trachea, soft tissues neck, we have intrinsic muscles of tongue, we have thyroid gland, strap muscles, esophagus. T4B, again same, prevertebral, posteriorly, mediastinal, anteriorly, and carotid artery. Let us talk about the nodal status now. So nodal status, we all know NX will be it cannot be assessed, N0 will be no node. Now three numbers we have to remember: less than or equal to 3 centimeter, less than or equal to 3 centimeter, to less than or equal to 6 centimeter. Okay, and we have to remember more than 6 centimeter. So that's how the nodal size is divided. First, we'll look into the numbers. So N1 is a node that is less than or equal to 3 centimeters. N2A is divided into 3, but the number will be same. It will be more than 3 centimeter, but less than 6 centimeter, more than 3 centimeter, less than 6 centimeter, more than 3 centimeter, and less than 6 centimeter. And N3 will be more than 6 centimeter. But N3 is also divided on the basis of extranodal extension that we'll discuss further. But N3, you have to remember it is more than. So this one is our N3. This comes in N2 and this is our N1, okay, according to the size. Now we need to know whether, so these are the two sides of body. So we need to know whether the lymph node is present on one side, or it is present on both the sides, or they are multiple, or they are single, okay, or it is only present on the contralateral side. So very easy. N1 is single ipsilateral, N2A is also single ipsilateral. Now what comes next to single? It can either be multiple. So it has turned into multiple ipsilateral lymph node. N2C, however, it could be a bilateral lymph node status, or it could be only contralateral lymph node that I told here. So this is the only contralateral. The disease is here in right side, but the lymph node is on the opposite side. Okay, and N3 is dependent only on the size. If it is a more than 6 centimeter lymph node, it will stage to N3. Okay, so what we did here was, in N2A what happens? There is a single ipsilateral lymph node. In N2B what happens? There comes multiple lymph nodes, but on the same side. In N2C we have either both sides lymph node will be there, or only on one side lymph node will be there. Okay, that is N2C. Now N3 is also divided into N2A and N2B. So N2A is any lymph node more than 6 centimeter. N2B will be any node, but it has extranodal extension. Okay, so what is extranodal extension? Extranodal extension means that the tumor has gone beyond the lymph node capsule. So tumor growth beyond the lymph node capsule. It shows us how aggressive the tumor is. It also indicates the increased risk of metastasis, and it also tells us that it is a poor prognostic factor. Now, extranodal extension has various determinants, physiologically or radiologically. Those are, that is, the skin infiltration is positive, muscle infiltration is positive, adjacent structures are involved, and neural innervation like brachial plexus involvement, phrenic nerve, sympathetic chain, and cranial nerve. So extranodal extension, if positive, whether it is any size of the lymph node, whether it is bilateral, contralateral, or ipsilateral, if there is extranodal extension, that is the growth beyond the lymph node capsule, we will consider it as N3B. Okay, so N3B only amongst these all, N3B only will show you extranodal extension positive. Rest all, we have negative extranodal extension status, and that's how we can strategize the treatment. And the treatment will all depend upon what is the lymph node state, what is the extranodal extension, bilateral, contralateral, what is the size of the lymph node. Next, let's dive into how we stage this cancer. So this can be staged into stage 0, stage 1, stage 2, stage 3, stage 4A, stage 4B, and stage 4C. Let me simplify this. Mets will be 0 in all except 4C. So we have Mets present only in stage 4C. Okay. Then we have to remember N3. N3 is the nodal status that is present only in stage 4B. Then we have stage N2. This is the N2 nodal status that is only present in stage 4A. So 4A has N2, 4B has N3, and 4C has Mets. Then stage 3 has nodal status N1. N1 is also present with stage 4A. So N1 stage 3, N2 stage 4A, and N3 stage 4B, Mets in 4C. This was only to simplify this. Now let us look into the stage 0. So 0 means there is no carcinoma, but there is carcinoma in situ. That we have to remember. No nodes, no Mets. Then stage 1. Stage 1 will be T1, but no nodes, no Mets. Stage 2 likewise will be T2, no nodes, no Mets. Then stage 3. So 1 is the simpler form where it's T3, but no nodes and no Mets. But further, it could be T1 according to the TNM. It could be T2, it could be T3, but the nodal status would be N1, as I told you. So if N1 comes with any T stage till T3, that means it is stage 3. Stage 4, simpler form will be T4A, no node, no Mets. T4A, again, we can have nodal 1, but no Mets. Then, if nodal status 2 is represented, then it could be with T1, T2, T3, T4 till T4A. So, all the T status till now that we have read with N2. So, N2 will have, if N2 is there, stage 4. If N1 is there, stage 3. Now, stage 4B. Stage 4B is T4B. So, then you can take any node and Mets will be 0. Or you can take any T, but N3 is the nodal status. So N3 in stage 4B. Then stage 4C, we know Mets present, so it could be any T or any N. So the thing you have to remember the most is, if N1 is coming, nodal status N1, no matter what the T stage is, it is stage 3. If N2 is coming, no matter what the T stage is, it is